This lecture will talk about diagnostic tests and procedures that are used for looking at disorders of the cardiovascular system. This slide lists a lot of different diagnostic tests and procedures here. A chest radiography or chest x-ray can tell you the size, position, and the contour of the heart, can also show you some of the structures of the heart. You can see calcifications or fluid around the heart. If you have a pacemaker, you can see placement of pacemaker leads. You can also look at the presence of pulmonary artery catheters, if indeed those are present. Fluoroscope is a special kind of luminescent X-ray screen that gives you a visual in real time that is used to guide a cardiac catheterization or to use for pacemaker lead insertion. Cardiopulmonary exercise test is a stress test. We'll talk about that a little bit on the next slide. Echocardiography is basically an ultrasound that looks at pressures and flow in the heart. We talked about that in A and P about how blood movement through the heart depends on volumes and pressure, and that's something they can measure on an echo. A stress echo is basically an echo that you do when someone is exercising. They put them on a bike and do that. There's an echocardiogram with an, I can't say this word, so I'm just going to say TEE, but they have an esophageogastroscope, I guess. That they put in, and you can do the ultrasound through the esophagus. And then nuclear imaging, they can do radioactive dye in the veins, and then that will show up as the blood goes through the veins and through the heart. Cardiac cath is an example of nuclear imaging. Mugascan is another example of that. An exercise test, sometimes called a stress test, sometimes called a cardiopulmonary exercise test, measures cardiac function, exercise tolerance, and peripheral vascular disease during a defined exercise protocol. So in order to measure each one of these things, there's a definite speed at which you're walking, an incline at which you're walking, and this shows the heart's response to increased oxygen needs with exercise. They can use it also for evaluating coronary artery disease. So they can also use it to plan for cardiac rehab. So if you have somebody who has had an event like an MI and they're going into cardiac rehab, they will have a baseline stress test, and then they will go through the exercise program and then do another stress test to evaluate progress. So before the test, you don't want them to smoke, eat, or drink for 2 hours. They, of course, really need to wear comfortable clothes and shoes, walking shoes. Make sure they have a sort of a loose top on for lead placement because they do have EKG leads on. Then you get baseline vitals. They exercise on the treadmill or on an exercise bike, or sometimes there's a stair thing too they can use. And then during the exercise, they measure vital signs, SATs, ECG, and any symptoms. The test is considered completed once they hit their peak heart rate, which is generally 220 minus your age, or if they experience any kind of chest pain, stop during fatigue, they're just unable to go any farther, or if they have vital signs or ECG changes. And then they monitor them post-test until they return to their baseline. We talked about the electrophysiology of the heart just a little bit when we did in the A and P, and here is how you can objectively measure the electrophysiology of the heart through an electrocardiographic rhythm strip, an ECG or an EKG reading. So what you have here is the electrical activity in one cardiac cycle. I don't expect you to know this. It's something you may or may not be asked on an ATI test or on boards, but unless you work in telemetry or in the ICU or in a cardiac clinic, there's no reason that you will need to know this. And so I'm telling you just for the sake of your learning, but I would not spend a whole lot of time fretting over this. There's a lot of other things more important for you to know. Um, so you got your little P wave there in the beginning, which is atrial depolarization. You remember that starts at the SA node and goes through the right atria over to the left atria. Then your PR interval, which is when it stops for just a little while at the AV node to kind of give time for the atria to contract. Then you have your impulse moving through the AV node, the bundle and the bundle branches in the QRS complex, and that's when the ventricles depolarize. Your ST segment then represents the interval between ventricular depolarization and repolarization. So that's right after the contraction. And then the T wave is repolarization of the ventricles. And so that's what you see as a one cardiac cycle. So you can look at this in a number of different ways. One way is just to look at a rhythm strip. So this is a rhythm on one lead. This happens to be lead 2. Obtain a strip with at least, and you look at the strip and you look at there's small squares and large squares. And again, just FYI, I don't expect you to commit this to memory. If you're really interested, we've got a great EKG class at the school here. But anyway, so you calculate the rate, and how to do that, you calculate the distance between from P wave to P wave and from QRS to QRS and make sure those match. Then when you measure the PR interval, which is the distance between the beginning of the P and the beginning of the QRS, that's important. And then you look at the difference between, or the duration, excuse me, of the QRS, so from the beginning to the end of that complex. And all of those different measurements of electrical activity will tell you something about what the heart's doing. So another way to look at this is to look at all 12 leads at once, and they call this 12-lead electrocardiogram. It measures the electrical activity of the heart at one point in time, but from different viewpoints. So the rhythm strip is from one viewpoint over time, and EKG is one point in time from various viewpoints. That's the difference. And of course, the little squiggles and points will go different directions depending on which lead you're looking at, depending on the direction that the electricity is flowing either to the electrode or from the electrode. So a 12 lead is called a 12 lead because there are 12 places that you put electrodes, and then you measure the conduction from those different points. You have a right arm, right leg, left arm, left leg, and then there are chest leads as well. The abnormalities that you can detect are abnormalities of actual electrical conduction. You can look at rate and rhythm. You can also measure ventricular hypertrophy, which will have an effect on conduction. You can use a 12-lead EKG to diagnose an MI, often used for electrolyte imbalances, specifically potassium, looking at different kinds of dysrhythmias and heart blocks. And these electrodes that you use this for, you put them on the skin of the chest and the extremities. If you're doing a 12 lead, you put the little sticky leads on, do the 12 lead and take them off. If you are monitoring someone on telemetry, you will leave the leads on. And usually that is done in a specialized unit in the hospital. You can also, and we'll talk about this in a little bit, leave them on long term for a long-term monitoring process at home. This illustrates telemetry, which is the monitoring of one lead continuously over a period of time. It is used, as I mentioned, in a hospital bed most of the time. In a telemetry unit, it can be portable. However, you can put them on a battery so that the patient can move around different places as an inpatient. Usually 3 leads are available. And then you can print out a rhythm strip at any point in time so that you can see what's going on. There's also a continuous monitoring that you can do as an outpatient with either leads, as this guy has on with what we call a Holter monitor, or a Zeo patch, which is not the different leads, but just one little patch that you place in a certain place in your chest. And what this does is it monitors for an arrhythmia over a longer period of time, usually 2 to 3 days, and people will monitor their activity and write in a little diary. I went for a walk, I climbed some stairs, I did this, I did that. And then also, did you have symptoms? Did you feel palpitations or chest pain or whatever? So it's used for outpatient diagnostics. There are tests that you can do to visualize vessels themselves and also the blood flow through the vessels. There are a variety of tests you can do that some of them actually don't have anything to do with the vessels, but the blood itself, CBC, UA, lipids, those kinds of things. But then the ones that have to do with the blood, the vessels themselves. So a Doppler, which is a special kind of an ultrasound, is a flow study, and it looks at the blood flow through the vessels. Angiography is when you put a dye into the vascular system to be able to visualize the vessels. You can use this to diagnose clots, peripheral vascular disease. You can test veins to use for grafting. Also, cardiac cath is a special kind of an angiogram that is done under fluoroscopy. And that will be discussed later in the chapter on, or excuse me, the PowerPoint on cardiac artery disease. Another thing that you can do is a VQ scan for pulmonary embolus, which we discussed in the respiratory system, but just to review here, they use radiopaque dye in the vascular system, and then they inhale uh, air that has a radioactive marker in it, and then they look at the lung to see for areas of ventilation and perfusion mismatch, areas where there is ventilation and there is no perfusion, and that is a clue that there might be a risk for a clot there. The ankle brachial index, or ABI, evaluates the arterial status in your lower extremities. It's a very inexpensive, non-invasive screening test, and it is basically a blood pressure cuff and a Doppler is what you need. A regular blood pressure cuff is placed above the malleolus on the ankle, and then another one is positioned over the brachial artery like you were taking a regular blood pressure. Then a Doppler probe is used to check the systolic endpoint of the pressure at the dorsalis pedis and posttibial sites. And then the brachial blood pressure is measured. And so what you do is you divide the ankle pressure by the brachial pressure, and if they're 1, because remember a number divided by itself is 1, so if an ABI of 1 or more is considered normal, an abnormal one means that you've got some arterial disease and you don't have quite as good a pressure and perfusion in your lower extremities, and that can confirm a vascular cause for ischemic pain in the legs at rest or intermittent claudication when you're walking. And finally, just a little bit about lab tests here. A C-reactive protein, or a CRP, is a measure of inflammation, and it has been shown recently that low-grade inflammation in the coronary vessels shows an increased for MI risks, or an elevated CRP can, in somebody with angina, indicates that you've got a little bit of a higher risk for an MI. Homeocysteine is another protein that's listed, linked to MI risk. I don't really expect you to know anything about that. Creatine kinase, CK is the abbreviation for that, and CKMB, MB being myocardial band. So that's the specific myocardial protein that is, or excuse me, it's an enzyme that's released from damaged muscle cells. So what happens is, if you damage your muscle, it will release creatine kinase, and different muscles have different kinds of this enzyme. Heart muscles have a specific kind that have what they call a myocardial band, or an MB. So if you've got damaged muscle, as you would have in a myocardial infarction, the level of this enzyme will rise in 6 hours, and then it'll be back to baseline in 72 hours. Troponin is a cardiac cell protein. They call it a cell marker. It can be elevated in a myocardial infarction within a few hours. Some people say 2. Most of the time it's between, I think, 3 and 6. It depends on what lab you use, but it can remain elevated for 7 days after the damage. Myoglobin is a cardiac cell protein. It rises an hour post-MI and peaks 4 to 12. I don't necessarily need you to know that. The troponin is what people are using now as a more definitive marker for an MI, and so that's probably the one that we will look at most, and we'll talk about that in the lecture on MIs. And then, of course, lipoproteins are very important. I'm talking about cholesterol, total cholesterol, low density lipoproteins, so those are the bad cholesterols. High density lipoproteins, those are the good cholesterols. And triglycerides is another fat that we're interested in. And of course, this can tell you a lot about coronary artery disease risk. And just so that you remember that LDLs are bad and HDLs are actually cardioprotective. So that ratio between the two is important to look at, not just the total cholesterol number.